Good morning, everyone. Thank you for joining us for this week's virtual journal club. My name is JP Brito. I'm one of the endocrinologists at Mayo Clinic and co-host of this series. Today, we're going to discuss this wonderful paper, Follicular Hurthle Cell Carcinoma, comparison of clinical pathological features and clinical outcomes. And to discuss this paper, we have two wonderful speakers with us. We have Professor Ian Ganly. Dr. Ganly received his medical training in otolaryngology at University of Glasgow, teaching hospital in Scotland, and in head and neck surgery, surgical oncology and Memorial Sloan Kettering cancer. He is a professor of head and neck surgery at Memorial Sloan Kettering Cancer Center and professor of otolaryngology, head and neck surgery at Wells Cornell. His clinical research interests are in outcomes research, focusing mainly in thyroid cancer, for which he has published more than 300 peer-reviewed scientific articles and many book chapters. In addition, he carries out translational research in oncogenomics of thyroid cancer, pathogenesis with particular interest in Hurthle cell cancer. And as an expert discussant, we also have the honor to have Dr. Peter Sadow. Dr. Peter Sadow is the director and head and neck pathology at Massachusetts General Hospital and has over 2 decades of experience in the medical field. He received his MD and PhD from the University of Chicago and continued his clinical training in anatomic pathology at Brigham and Women's Hospital. His main research interests include endocrine pathology and the mechanisms of endocrine carcinogenesis. He also has prominent teaching roles in the hospital, medical school, and in continuing medical education courses. And with that, I will turn it over to you, Dr. Ganly, to start your presentation. Thank you very much for being with us.
Okay, thank you very much for that kind introduction. The paper that we're going to discuss today is this one here, Follicular and Hurthle Cell Carcinoma, Comparison of Clinicopathological Features and Clinical Outcomes, which was just published in Thyroid this year. I have no financial disclosures. So, Hurthle cell cancer and follicular thyroid cancer are both rare, and each accounts for only 2% of all thyroid cancer. Previously, Hurthle cell cancer was actually considered an oncocytic variant of follicular thyroid cancer, but the World Health Organization now classifies Hurthle cell cancer as a separate entity. And this is largely as a result of several genomics research papers, 2 of which were published in Cancer Cell, one from our group at Memorial Sloan Kettering, and the other from Peter's group at Harvard in Boston. And these references are shown here on the right-hand side. Now, there is controversy about which of these 2 cancers is most aggressive. There's also controversy about the classification of vascular invasion, the extent of vascular invasion, and its impact on outcome. Therefore, the objective of this study was therefore to compare clinical pathological characteristics between these 2 histologies. Secondly, to compare the oncological outcomes. And lastly, to assess the impact of vascular invasion and the extent of vascular invasion on outcome. After IRB approval, 190 patients with follicular thyroid cancer and Hurthle cell cancer were identified from an institutional database of 6,259 patients with well-differentiated thyroid cancer, treated at Memorial Sloan Kettering between 1985 and 2015. All of these patients had primary surgery at Memorial Sloan Kettering. Patients who had had treatment at other institutions were not included in this analysis. All of the slides were reviewed by 2 experienced thyroid pathologists, and these were Ronnie Gussain and Ben Zhu, and classified each tumor according to the 2017 WHO guidelines. Patients with poorly differentiated thyroid cancer, as defined by the presence of mitosis and necrosis, were not included in this analysis. Now, distinguishing carcinoma from adenoma is based upon the presence of capsule and vascular invasion. With regards to the definition of Hurthle cell cancer, the cell of origin is thought to be from the follicular epithelium. And these Hurthle cells are oncocytic cells. They're large polygonal cells with abundant eosinophilic and granular cytoplasm due to the accumulation of thousands of dysfunctional mitochondria. And this is an electron microscopy photograph of a Hurthle cell showing the cell nucleus surrounded by these thousands of mitochondria. A lesion is considered a Hurthle cell cancer only when greater than 75% of tumor cells are composed of these oncocytic cells. And we require to have capsule invasion or vascular invasion. So this slide here, for example, this shows a minimally invasive follicular cancer, which has one focus of capsule invasion, which is shown with the black arrows, in which we have a mushroom-shaped tumor bud penetrating through the tumor capsule. This here shows vascular invasion. Vascular invasion was defined as when we had foci present within or beyond the tumor capsule, and the invasive focus protruded into the lumen of a vessel in a polypoid fashion. So this H&E slide shows tumor cells invading the blood vessels in the capsule of a Hurthle cell carcinoma. Now, the WHO classification now classifies according to this these categories. So if we have an encapsulated lesion with capsule invasion only, these tumors are classified as minimally invasive. If we have an encapsulated lesion with angioinvasion, that's EA, they're classified into two types. We can either have focal vascular invasion, which is less than 4 foci of vascular invasion, or they're encapsulated angioinvasive with extensive vascular invasion. And then thirdly, we have gross invasion of capsule with extensive vascular invasion, and these tumors are classified as widely invasive cancers. For the comparison, the clinical pathological characteristics were compared using chi-square tests for categorical variables and the Mann-Whitney test for continuous variables. And then outcomes were compared using the Kaplan-Meier method and compared using the log rank test. Got to start my video. Okay, results. Okay. So this is the pathology classification for follicular thyroid cancer. We had 79 follicular thyroid carcinomas, and 40 of these were classified as minimally invasive. That's 51% of the cohort. We had 23 encapsulated angioinvasive with focal vascular invasion. 15 patients, that's 19%, with encapsulated angioinvasive extensive vascular invasion. And then we actually only had one patient with widely invasive follicular thyroid cancer. And then for the Hurthle cell cancers, we had 42 or 38% patients with minimally invasive, 28% with encapsulated focal vascular invasion, 27% with encapsulated extensive vascular invasion, and 7% with widely invasive Hurthle cell cancer. So table 1 in the paper shows a comparison of the clinical and tumor characteristics by histology. And for Hurthle cell cancer, patients presented at an older age compared to follicular thyroid cancer. So 59% of the patients are over the age of 55 compared to only 27% in follicular thyroid cancer. The other difference between the groups was the extent of vascular invasion. So vascular invasion was more extensive in the Hurthle cell cancer tumors compared to the follicular thyroid cancer tumors. That was 33% compared to 19%. There was no difference in gender in the T stage, tumor size, extrathyroidal extension, and in the end stage. And these photographs here, these actually show a patient with Hurthle cell cancer. And the reason I'm showing that is just to show that on PET scan, they're incredibly hypermetabolic. And this is due to the change in the metabolic profile of these tumors towards glycolysis and not through the Krebs cycle. So they are very high glucose consumers and very high SUV values using PET scans. Okay, this slide here, this shows a figure of how we treated the patients. So treatment and outcome. I'm just going to go from left to right. I'll just go through each category and how we treated the patients and what the outcomes were. So on the left-hand side, we see that of the minimally invasive follicular thyroid cancer patients, 57% of these were treated with total thyroidectomy, and 25% had radioactive iodine. And then as we move towards the encapsulated angioinvasive tumors with focal vascular invasion, we see more patients getting treated with total thyroidectomy and more patients getting radioactive iodine, 61%. And then as we get extensive vascular invasion, again, 87% getting total thyroidectomy and 87% getting radioactive iodine. And lastly, for the widely invasive patient, that patient was treated with total thyroidectomy and, of course, radioactive iodine. Now, overall, of these 79 patients, the outcomes actually were remarkably good. There was actually only one death, and that death was in the patient that had encapsulated angioinvasive cancer with extensive vascular invasion. There was, in fact, no local regional recurrences, and 2 patients had distant recurrence, one of whom has died, but the other still alive. This shows the same figure, but this time for Hurthle cell cancer, and you can see, again, moving from left to right, the minimally invasive cancers, 76% had total thyroidectomy, and 19% had radioactive iodine. For the focal vascular invasive group, 71% total thyroidectomy, 29% radioactive iodine. For the extensive vascular invasion, 90% total thyroidectomy, 83% radioactive iodine. And if we move to the widely invasive, 57% of total thyroidectomy, which is less than what you might expect, and 38% had radioactive iodine, also less than what you might expect. We can actually discuss that at the end. Overall, there were 6 deaths from cancer, 4 with the extensive vascular invasion group, and 1 in the focal vascular invasion group, and 1 actually in the minimally invasive Hurthle cell cancer actually died. And this is I would call this a rarity. This was a patient who actually presented with distant metastasis at presentation. Incredibly rare, because this patient had no evidence of vascular invasion on the pathology review. So of the widely invasive cancer patients, they're actually all still alive, though some have distant recurrence. Now there's 3 local regional recurrences, 2 in the extensive vascular invasion group and 1 in the focal group, and 5 patients with distant recurrence, 1 widely invasive, 3 extensive vascular invasion, and 1 focal vascular invasion. So how did these groups do? Well, you can see from the small number of cases and events, it's difficult to do a statistical analysis on outcomes. So what we did was that we grouped the groups together. So group 1, was basically comprised the follicular thyroid cancer group, minimally invasive, along with the follicular thyroid cancer encapsulated angioinvasive with focal vascular invasion. So we're calling that group 1. Group 2 was the follicular cancer extensive vascular invasion and widely invasive. And then group 3, that is the Hurthle cell cancer group, which is minimally invasive with focal vascular invasion. And then group 4, that is the extensive vascular invasion and widely invasive group. And here are the Kaplan-Meier survival plots. So the nice thing about this is we've actually got a long-term follow-up on many of these patients. The median follow-up was 83 months. The top left is overall survival. The top right is disease-specific survival. The bottom left is recurrence-free survival, and the bottom right is distant recurrence-free survival. And you can see in all four plots that the purple line, which represents group 4, which is the Hurthle cell cancer group with the extensive vascular invasion and widely invasive group, you can see that this is the group that has the poorest overall survival, poorest disease-specific survival, highest recurrence, and highest distant recurrence as well. Now, we're interested in the meaning of vascular invasion and the extent of vascular invasion and what this actually, how this impacts outcome. So here, this is table 4 in the paper, which describes outcomes stratified by the extent of vascular invasion. And patients who have no vascular invasion, they're actually shown in the green box on the left. And then the patients with vascular invasion, they're shown on the right in the red box. And you can see clearly that the patients who have the vascular invasion are more likely to die of thyroid cancer, have local regional recurrence, have distant recurrence, and also present with M1 at presentation. And you can see in the middle 2 columns that these poor outcomes are all driven by the patients that actually have the extensive vascular invasion, which is greater than or equal to 4 foci of vascular invasion. And here are the Kaplan-Meier plots here. So this figure basically stratifies the patients according to the extent of vascular invasion. So this includes the follicular thyroid cancer and Hurthle cell cancer groups together. And again, it's the same. Top left is overall survival. Top right is disease-specific survival. Bottom left, recurrence-free survival. And the bottom right, distant recurrence-free survival. And you can see that the patients in blue, they are patients with no vascular invasion. The green lines are focal vascular invasion, and the red is the extensive vascular invasion cohort. And you can see that patients with the extensive vascular invasion, shown in red, have the poorest survival and the poorest recurrence-free survival and distant recurrence-free survival. So the study obviously has got limitations as well as strengths. So the main limitation is it's a small sample size. It's only 190 patients. But believe it or not, it's actually one of the largest series in the literature. So basically what we're dealing here with is rare cancers. So it's difficult to get the numbers. There's also the intrinsic limitation of retrospective design and limitations by selection bias and treatment, and also possibly a referral bias because it's patients were treated at a tertiary referral centre and obviously were not. There may be a bias there with the type of patient that we see. The strengths, however, is the fact we've got detailed pathological review in all of these cases by 2 expert thyroid pathologists. And also we actually have long-term follow-up, which allows us to do these outcomes analysis. In conclusion, the study highlights that both the extent of vascular invasion and the histological phenotype are of great importance when predicting clinical outcomes. They help stratify the patients for therapy, especially regarding completion thyroidectomy, radioactive iodine therapy, and also the type of systemic therapy for distant disease. And compared to other subtypes of Hurthle cell cancer and follicular thyroid cancer, it's really patients who have Hurthle cell cancer, encapsulative, angioinvasive, extensive vascular invasion, and the widely invasive Hurthle cell cancer, which are the patients most likely to recur, have poorer distant control, and more likely to die from cancer. So with that, I'd like to conclude, and I would like now to pass over the baton to Dr. Peter Sadow from Harvard for the discussion. Okay, thank you very much.
Thank you, Dr. Ganly.
like stop sharing. Okay.
So it's really great to be able to have this discussion because it's two different perspectives. You have the clinical perspective, and one of the things that the advantage that Dr. Ganly has is he has Ronnie Gossain and Ben Chu as his two primary pathologists who focus on thyroid disease. And so one of the baseline assumptions that you need to make, first, my disclosures, no disclosure, I disclose that I love thyroids. And I want to talk to you about the background, because one of the assumptions that Dr. Ganly is able to make is that the diagnoses are correct. And that one of the things that many patients don't understand, and certainly some endocrinologists don't understand as well, is that the diagnosis of these lesions is exceptionally subjective. And the idea of widely invasive, minimally invasive, vascular invasion, capsular invasion is very subjective from the pathologist. There's no machine that we place these things in that just pop out and tells us vascular invasion and capsular invasion. So the assumption is that the diagnosis is correct. And that is one of the major problems and discussions that we have in endocrine pathology. And certainly, as many of you have heard of the diagnosis of NIFT-P, the non-invasive follicular thyroid neoplasm with papillary-like nuclear features, endocrine pathologists in general also have difficulty coming up with a conclusion in terms of the overall final diagnosis. So this is sort of the next realm. One of the the main thing, capsular invasion, minimally invasive versus widely invasive. When we talk about encapsulated angioinvasion, we talk about focal angioinvasion as they do in the paper, and extensive angioinvasion. And then we talk about the same exact things for oncocytic or Hurthle cell carcinomas versus follicular thyroid carcinoma. So we have the new edition of the WHO in 2022, which is now available for people to see online. And we have minimally invasive with capsular invasion only, encapsulated angioinvasion with minimal or extensive vascular invasion, and widely invasive follicular thyroid carcinomas, and exactly the same thing for oncocytic thyroid carcinomas. Previously, these were grouped together. Now they're grouped as separate tumor types, specifically because of the studies that Dr. Ganly mentioned that really prove that the oncocytic or Hurthle cell carcinomas, that's the other thing, Hurthle cell went away again, now it's oncocytic carcinomas, that they actually are biologically distinct animals, and therefore they're categorized separately, but the actual way we classify them is still under these same three category types. So follicular thyroid carcinomas, angioinvasion, which typically should be considered to be venous invasion, can lead to distant metastasis, and these are typically involving the RAS family of mutations. And oncocytic or Hurthle cell carcinomas, also angioinvasion typically heralds distinct metastasis, but also distinct from follicular thyroid carcinomas, these oncocytic or Hurthle cell carcinomas can have local lymph node metastasis, which is quite different than typically we think of follicular thyroid carcinomas. And they have distinct genetics, as Dr. Ganly explained to you, that have been recently published in 2018. So the issue ends up being, I mentioned to you, is this idea of capsular invasion. Now, one of the things that these papers don't take into account is the absolute paranoia of pathologists, because when a diagnosis is subjective, you take into account of not only what is the diagnosis, but who is going to see this case after you, right? So patients, when they have a diagnosis of thyroid cancer, oftentimes, or when any patient has a diagnosis of cancer, they're going to want to get a second opinion. And so, for instance, patients that live in the New York area may go for a second opinion at Memorial. Patients in the New England area may go for a second opinion at Massachusetts General Hospital or Brigham and Women's Hospital. And you have to take into account the individual personalities of the pathologists involved to know whether or not a particular pathologist tends to be more aggressive with their diagnosis, which I mentioned to you are subjective, or more conservative with their diagnosis. And so you can get an entirely different diagnosis depending on which pathologist reviews the case. And one of the issues that was not particularly mentioned, specifically in Hurthle cell or oncocytic neoplasia, is that these tumors tend to be fairly large or can be fairly large. When tumors are fairly large, it sets off alarm bells for the pathologist that they're going to miss a small focus of capsular invasion or a small focus of vascular invasion, and pathologists will go out of their way to make a diagnosis of carcinoma so as not to be wrong, because in the back of their mind, this is, so I'm just revealing psychiatry here, or psychology, that pathologists are terrified that they're going to have a lawsuit, that they're going to miss a cancer, and that the patients are going to have a recurrence of disease, and the pathologist is going to get sued because somebody else is going to look at this case and say it's cancer. So pathologists actually are more, in general, not in specialty centers, but they're more inclined to favor invasion versus not invasion when they feel like there's a possibility it's going to come back to haunt them. So in a case like this that you're seeing now, where you can see that the tumor seems to minimally breach into this fibrous capsule, the question is being, is it invasion or not? The answer is no, but this is certainly a focus that would cause some difficulty for a pathologist, versus this particular focus that you see here, where you see this large mushroom going outside of the main confines of this pink fibrous capsule below, and there'd be no pathologist has a question to say that this is overt capsular invasion. Okay, but that's the difficulty. So then we talk about how we actually review these tumors. And so the typical way we do it is we actually review the entire capsule, because if you want to assess for tumor invasion, you actually need to look at the entire periphery of the tumor to say whether or not that tumor is invaded through the capsule or into blood vessels within the capsule. You need to inspect the entire capsule. So that's typical routine practice in the United States. More broadly in Europe, they tend to be more cost conscious in terms of the number of the cassettes that they're going to review, and they may have a smaller number of cases that they review. So that similarly with this publication by Dr. Ganly, we actually also underwent our review of follicular carcinomas, which did not include Hurthle cell carcinomas, over 25 years from 1990 to 2015. And we looked at all the cases that actually did metastasize. And when those cases that metastasized, we looked at whether or not the entire capsule was submitted, whether or not it made a difference. And so the answer is, if a tumor was widely invasive, this is something that the surgeons, the clinical team will actually know ahead of time by imaging. You can see that the tumor is not well circumscribed, it's widely invasive into the capsule. In those particular cases, those were the tumors most at risk for metastasis. And that ones that were, the ones that we struggle over, is it invasion, is it not invasion? Those typically we don't care about. They never metastasize. It's not important at all. And even in the case of Dr. Ganly, he showed one case with minimal invasion, with no vascular invasion, and that one was present with metastasis at the time of diagnosis, and that patient died. And in this particular case, we also had a case of a follicular adenoma in which the entire capsule was submitted, but that patient ended up having widely metastatic disease. So the issue ends up being that we don't particularly know, and the gross evaluation, even microscopic evaluation, isn't necessarily going to be the best predictor in terms of tumor behavior. So the summary is that the widely invasive carcinomas are overtly the worst tumors you can get. Extensive vascular invasions, much greater risk for distant disease, and most carcinomas, whether they're follicular or oncocytic Hurthle cell, are essentially non-worrisome. So the issue ends up being for us is that we need to be able to figure out which of these tumors are going to be bad from which of these tumors aren't going to be bad. And it's going to be something biological. And so sort of the tip of the iceberg is this publication, this co-publication in 2018, showing that oncocytic or Hurthle cell carcinomas are very different biologically from classical follicular thyroid carcinomas. And we really need to take a deeper look at what we consider to be minimally invasive tumors, even with minimal or focal vascular invasion, to try to kind of, I want to say, destigmatize these in the eyes of pathologists, because like I said, the pathologist is looking at these diagnoses when we see them under the microscope is what is the worst possible case scenario. So the worst possible case scenario, okay, we know about T stage, so that involves the tumor size. And then we start saying, what can make this tumor worse? What can make this tumor worse is invasion through the capsule. What can make this tumor worse is vascular invasion. What can make this tumor worse is the case being referred to another pathologist that calls everything vascular invasion or capsular invasion and potentially may have some biological potential. So the only way to take the lower risk cancers out of a lower risk category is to have some sort of objective biological marker that's going to say, absolutely, based on this biological profile, these tumors are at very, very low risk for metastasis. And certainly we know that all of them are at very low risk for death. I mean, if you are going to look at a retrospective study at Memorial Sloan Kettering, which sees a very high risk group of tumors, again, they only see patients with carcinomas, or at least at risk for carcinoma, and show that only a very small subset of patients have died of this disease, then you know that overall for the general population that the disease risk is extremely low. But every single one of these cases of the several hundred cases that we all see each year in subspecialty centers have such a low risk of bad behavior that we really need to understand what it is about these tumors that are going to cause this bad behavior, so that we can kind of get over the idea of being kind of overruled by another pathologist in terms of the minimal disease, which makes no difference whatsoever. So I think that's kind of where we are. I think the great thing about this publication is show that there can be, in terms of Hurthle cell tumors, it does sort of fit that they can be more aggressive, they can be multifocal, they can be distant metastasis, et cetera, relative to some follicular thyroid carcinomas, again, a different biological pathway, but the overall risk of death from disease is significantly pretty low. So even in that particular circumstance, we need to take a different pathway in terms of how we look at this disease, how we approach this disease, and even how we diagnose the disease, especially for the categories that Dr. Ganly pointed out, in that group 1 and group 3, kind of the low risk follicular thyroid carcinomas and the low risk oncocytic or Hurthle cell carcinomas, how we actually look at them in terms of how we diagnose them, how patients perceive them, how our clinical colleagues perceive them, so that we know how to behave appropriately with these patients, that we don't want the ones at super high risk to fall through the cracks. So increased molecular data increases our understanding of the tumor biology, and targeted therapeutics are not very particularly useful for follicular and oncocytic thyroid carcinoma pathways at the current time that we have for some other thyroid cancers. And so clinical pathologic correlation is the best chance for prognosis in this disease, as proven by this paper. But pathologists need more rational means for assessing extent of vascular invasion, assessing capsular invasion, in order to be able to make the correct diagnosis for patients and also for our clinical colleagues in terms of determining next steps. And according to the American Thyroid Association guidelines, for tumors that are 4 centimeters or less without any adverse biological signs, a lobectomy alone is complete treatment for these patients. And the problem is for pathologists is they're afraid, especially for Hurthle cell or oncocytic neoplasms, if they're on the larger side, which they often are, to kind of give a low grade malignancy at that point, because they're afraid that it's going to metastasize, and they'll look for any means possible to upgrade that diagnosis. So I think we need to find some way, whether it be a biological marker or psychological counseling, to be able to help pathologists be good partners in terms of the diagnosis of these particular neoplasms. And I think with that, I'm done with my commentary or discussion.
Thank you, Dr. Sadow, and thank you, Dr. Ganly, for wonderful presentations. So as a clinician, it worries me quite a bit, the reproducibility of reporting, and of course, it is from the perspective of deciding next steps. Challenging. Can you speak a little bit more about this agreement issue? So to what extent is very significant or not that significant? In other words, if I get to see a patient that comes to my doors with vascular invasion for a Hurthle cell, should I get a second opinion elsewhere to trying to come up with another perspective because of the issues of agreement?
Well, the answer, of course, the short answer is yes, but it's actually much more complicated than that, because pathologists actually know pathologists. So the subset of endocrine pathologists in the world, and specifically in the US, is small. So I know, for instance, I could do a consult with Ronnie in my head. I can do a consult with, Virginia Lavolsi or Sylvia Asa or any of these other well-known endocrine pathologists in my head because I know how they approach these lesions. So I can actually tell you what they're going to call any individual tumor that may be different than my opinion, but I actually know their opinion in my head, so I can say what they're going to say. This is a problem, right? This is an inherent difficulty. And I can tell you that this morning alone, it's Friday morning, but I've already received 16 email messages in this reply to all group that we're doing right now, because we're having a discussion of, okay, people recognize NIFT-P, and then the next challenge we're facing is this subset of tumors that are called well-differentiated tumors of uncertain malignant potential, minimally invasive tumors, things that people can't agree on. And the replies to all this morning are, at our institution, we do this. So everybody's offering their opinion, but there's no one actually able to sort of say overall, this is the way we need to approach this and why. Everyone says what they do and what their expectations are and why they think what they do is correct. But the idea of actually having a common understanding that we have differences of opinion and how to approach that is quite a challenge. So you're right. Yes, you could send for a second opinion, but you also know that sending for a second opinion is in itself a biased process, because anybody who has a feeling about what they want to call it, what the diagnosis they want to be, can choose who they're sending the second opinion to and know that 80% of the time, this one's going to call it cancer, 80% of the time, this one's going to call it benign, and none of it's the truth and all of it's the truth. So meaning that for minimally invasive disease, I think that Dr. Ganly's paper here shows you that for minimally invasive disease, it's essentially benign disease except for when it's not. And when it's not is a super rare exception. And this is how we need to communicate with patients. Because if patients understand that there's not zero risk associated with their tumor, but super low risk. And if for instance, in Dr. Ganly's case, the minimally invasive tumor had metastatic disease at the time of presentation, right? So already biologically, we knew that tumor was going to be bad. But if that particular tumor didn't have metastasis at the time of presentation, the risk of that actually metastasizing or causing the death of the patient is about zero, right? Or in the 0.1%, possibility of happening. So I think we need to change the way we look at this disease in order to be able to remove the paranoia from pathologists that they may or may not be incorrect and worry about somebody else reviewing the case, so that if we're able to appropriately explain the biological process to patients and say, hey, your chances of dying from this disease are so low as almost to not have this discussion, then it will sort of remove the stigma off of the minimally invasive or focal vascular invasion discussion that you have with your patients.
So it seems that if something, there is a tendency to overcall things. So it is possible that many follicular adenomas are actually some minimal invasive follicular cancers might be actually follicular adenomas that they overcall because maybe some protrusion into the thyroid capsule, but that might be
polite. I'm going to say that you're being polite because you're saying they are overtly adenomas that are being called minimally invasive carcinoma. But the problem is that I think there's an old expression that there are pathologists that call things benign, and there are pathologists that have been long enough to see something go wrong. So what ends up happening is the pathologists always have one anecdotal case in their career that they've called either minimally invasive or they called benign, that has subsequently metastasized, and then they never call another case benign again. And this is the problem. So this is saying that we have to remove this stigma away, because people tend to be, yes, absolutely 100%, there are adenomas or tumors of essentially zero biological potential that people are calling minimally invasive carcinoma. And so younger pathologists or more junior pathologists are much more likely to be cavalier in their diagnosis and call things adenoma and call things benign because they haven't had one go bad on them. And then there are more senior pathologists that had that one case they can point to that went bad, and therefore they don't do it anymore. It's a really problematic. And yet at the same time, so I'm still at the point, I'm 50 years old, okay? I have 20 years of experience in my field. I'm still one of those people that minimizes things. I'm still one of the people that's more likely to call something benign because I haven't had it come back and bite me, okay? But I'm at that age where, they're usually 20 years out is when they tend to recur. So I'm at that age where it's going to happen sometime probably within the next 2 weeks. And then I'm never going to call anything benign again. So I don't know, that's what I'm saying. We need to learn how to talk to our patients in a better way to explain their disease. We want to be reassuring without being dismissive. And that's where I think where this paper is very helpful, which should serve as good counsel for pathologists, but it yet oddly doesn't.
Yeah, and Dr. Ganly, briefly about this issue of agreement, you do have two pathologists, experts, pathologists there in this study. Did they agree on calling the same thing always?
Yes, so in the majority of cases, they do agree. And if they ever have any disagreement, obviously they then review together, and often they'll then get a third pathologist in to see if there's any push towards one way or the other. But like Peter, I mean, Ronnie Gussain's got years and years and years experience. I think he's older than you, Peter. So I think he's probably got over 20 years experience.
He's way over.
Yeah. I hope Ronnie's not on the phone, on the call. So yeah, he's got tremendous experience. I go by his judgment.
And so moving on to the clinical implications of these findings, one of the big questions is how the minimal invasive versus angio-invasive actually dictates the extent of surgery. Understanding that the decision-making happens in the OR sometimes, or after the OR. Ideally, for the patient's benefits, we don't want to take the patients back to the OR. At Mayo Clinic, we do rely quite heavily on frozen section. How accurate this capsular vascular invasion could be assessed in frozen section?
Well, you're asked, so there are Mayo Clinic specific questions versus the rest of the world. And well, it's true. Mayo Clinic is the only place in the entire world that does what they do. Assessing capsular and vascular invasion on frozen section, even at Mayo Clinic, is impossible and somewhat high risk in terms of what you're going to get for a permanent section. But I will tell you that in Dr. Ganly's paper, one of the things you see is talk about the number of vessels. Now, we all realize that vessels are a tube, right? They're long things. And the way we assess them is looking at a two-dimensional image that's flat on a slide that we see. And we might end up saying that there are two vessels involved because you see two foci of vascular invasion, but that actually may be the same vessel, right? So sort of cut as, you see one, because it's three-dimensional, and we're seeing a two-dimensional cut through it. So you might see one focus, and at 3 millimeters away, you see another focus, but actually it's the same vessel. So actually, even how we count these number of vessels of vascular invasion is somewhat subjective, even though you can say objectively, here's this vascular invasion, here's this vascular invasion, but very well may be the same vessel. So in the cases of minimally invasive carcinomas, minimally invasive, in those cases, or focal angio invasion, as is in the paper, Mayo Clinic is not going to be able to do it. So, God bless them. But at the same time, these subjective questions that are there, subjectively, the person on frozens at Mayo can say this is focal vascular invasion, this can say focal capsular invasion, but you're seeing from outcomes that these patients should be treated in a low risk fashion. They should not be coming back. So for instance, if the frozen person at Mayo says there's focal vascular invasion, there's focal capsular invasion, that patient should not be getting a total thyroidectomy unless there are other things clinically, preoperatively, like nodules on the other side. This patient's a high risk for not coming back. You've already had the discussion with the patient preoperatively that if we find focal whatever, we're going to do a total thyroidectomy. So all these things should have been preoperative discussions that happen about what you're going to do. And with the understanding that if there's focal vascular invasion or focal capsular invasion that's noted on frozen section, then you're going to do a total. If that's the discussion at Mayo, then that's the discussion at Mayo. But certainly major clinical decisions should not be made ever in thyroid cancer by frozen section. Sorry, Mayo.
No, that's fine. And actually, that's an area that we continue to discuss internally. Dr. Ganly, let me pose you something that I have been struggling with to understand. And for follicular cancers that clearly benefit from radioactive iodine, proceeding with total thyroidectomy for lateral lesions, I think might make sense when we think it might be aggressive with, for instance, angioinvasion. If radioactive iodine is not equally effective for Hurthle cells, what is the role of total thyroidectomy, for instance, even if we find patients with vascular invasion in the initial surgery? Why should we proceed with total thyroidectomy when we already think the radioactive iodine is not that effective?
Well, so for Hurthle cell cancer, the uptake of radioactive iodine or the avidity of radioactive iodine is dependent on this classification, actually. So in cancer cell, we actually looked at the expression of thyroid differentiation genes, the 16 thyroid differentiation genes, and we showed a really nice pattern where the minimally invasive cancers in Hurthle cell retain the expression of these genes, and therefore the minimally invasive ones can't take up radioactive iodine. But as you move towards the very aggressive ones, the widely invasive, you see that these genes are all lost. And therefore, the widely invasive cancers, they're not going to take up radioactive iodine. And you can see that when we look at the patients in our cohort, I mentioned that only 38% of the widely invasive cancers actually receive radioactive iodine. And this was because we knew that these cancers were not going to take up radioactive iodine. So I would say there's a spectrum. As you move along that spectrum towards the widely invasive cancers, the ability to take up radioactive iodine goes down, and therefore the utility of it is not as useful. And that's, of course, different in the follicular thyroid cancer types, because you see uptake, the radioactive iodine uptake is retained across that spectrum. So it's quite different. The two cancers are different in that respect. And we, of course, don't know why. We don't have a reason as to why the Hurthle cell cancers lose all of this expression. So that's one element that's different between the two groups. Peter mentioned we don't really know how to identify these patients from the beginning, particularly the Hurthle cell cancer patients. There are some molecular markers that can help. So, for example, the presence of TERT mutations. In our paper, we show that TERT mutations are universally only occur in the Hurthle cell cancers which are widely invasive or have more than 4 foci of vascular invasion. Roughly about 35% of those patients have that. And these patients do badly. Whereas the minimally invasive cancers, they don't have this. And then the other thing that we recognize is that the Hurthle cell cancers have a really crazy chromosomal landscape, very unique. There's no other cancers like that in the TCGA, very different from follicular cancer. And this unique chromosomal landscape where you see haploidization of chromosomes or uniparental disomy of chromosomes, basically is a spectrum. The minimally invasive cancers really don't show it. They tend to be mainly diploid. But as you move towards the bad cancers, their chromosomal landscape gets more and more aberrant. And we now know that as you develop this chromosomal landscape, you lose loss of tumor suppressive function, for example. So that's going to make your cancer more aggressive. And more recently, we've been doing some studies which actually show that as you develop these chromosomal patterns, the tumors tend to be more immunosuppressive. They actually become, I would classify them as immune deserts. So you see T-cell infiltration is dramatically dropped off in the aggressive Hurthle cell cancers. So these cancers develop an ability to hide from the immune system. So these are some areas that I think can help to try and categorize the patients into bad actors and good actors.
Fantastic. And This was a fantastic conversation and also fantastic presentations. Thank you, Dr. Ganly. Thank you, Dr. Sadow. We are at the end of the hour here. Any final thoughts, Dr. Sadow, Dr. Ganly?
Oh, it's great, great conversation. It's great to get Peter's perspective on it all, and also the emphasis as to how difficult it is and the controversy in classification of these cancers.
Yeah, we'll need follow-up from our people, and our people, I mean the pathologists, to try to, you know, again, we're very open to therapeutic processes, mentally therapeutic processes, because I think that's what we need in order to be successful and helpful to you all.
That the perspective of the pathologist actually is very impressive in regards how you think, how you make decisions. You know, it's a lot of things that happen there and we don't get to see it. So certainly it's very good to hear about it. And thank you, Dr. Sadow, again for joining us from your vacation home. I appreciate it. Sure. Thank you, Dr. Ali. Thank you, everybody. Take care.
Thank you. Okay, bye.
Bye.